Okay. Can we start?
Yeah, so just 1 minute. I'm just if we are live, and I think in my opinion, yes, we
Yeah, it is showing live. Meeting is now streaming live on YouTube.
it and yeah, the meeting is streaming live on YouTube, and we can start. No problem.
Yeah. So hi everybody. From the whole team today, I'll be welcoming all of you. So I welcome Dr. Dipesh and Dr. Sachin Dalal also for this session. So to introduce the speaker, Dr. Jai is a wholesome OBGYN who is doing pioneering work in laparoscopy and infertility. He's an academician, influencer, YouTuber with more than 3 lakh followers, and he's the founder of Project Pelvis with 18,300 gynecologists. And he is doing all the cases live on Facebook, which has been abandoned, which has been not been possible by many, just so that the youngsters can learn from it. And he does huge numbers in IVF. He has got great practical experience in clinical as well as embryology. He's been very selfless in teaching to all the gynecologists pan-India, just to benefit whatever mistakes he has done, to make sure that the youngsters don't do the same and to learn from him. So this initiation of having small focused topics like this on infertility and other topics on gynecology, which are very relevant in clinical practice, has been very hugely popular amongst all gynecs across India. We have done this in the past 2 sessions which have been viewed by many gynecologists across India, and it has been very popular. I think Dr. Jay has got very good feedback about these sessions. And over to you, Dr. Jay.
Yeah, so guys, we are going to start, and it's going to be it's going to be just 15 minutes, and we are starting. So first of all, I would like to acknowledge that this modified natural cycle is Dr. Sachin, there is some voice coming in from your background.
Yeah.
Okay. So I would just like to acknowledge that this entire protocol of modified natural cycle transfers, I'm sure it has been going on across the world for quite some time. It is not something which has been designed by me under any stretch of circumstances. Okay. But for a prolonged period of time, all of us who are doing frozen embryo transfers have been doing HRTs. Okay, so we are doing hormone stimulated cycles in the form of estradiol valerate, or whatever estrogen you are using, and then any form of progesterone to back it up, okay, for your luteal phase support. I think it was somebody who is very close to me, and Dr. Sachin Dalal, he deserves a big round of applause for getting this thing of doing natural cycles into the head of people, because I distinctly remember he had taken a session for all of us in lockdown, I guess sometime in around lockdown, where he had specifically mentioned about the practical points of doing a natural cycle transfer, a completely natural cycle transfer. And at that point in time, all of us were having a little apprehension that it is going to require a lot more monitoring. Okay, and because it requires a lot more monitoring as compared to your HRT stimulated cycles, what we were of the opinion is that because it is going to take, because it is going to take so much effort to sort of monitor these patients and all these things, because it is going to take so much effort to monitor all these things, we were of the opinion that, okay, probably we should be not doing it, So what we are going to present to you today, we are not going to get into the physiology, no anatomy, no such things of doing any form of, natural cycle transfers, modified natural cycle transfers. This is something, after listening to him, we shifted for approximately 50% of our work got shifted from HRT to modified natural cycles. And we all know the advantages. So there are multiple papers which are available to tell you advantages, that, you have a natural corpus luteum, which is going to give you a much better endometrial vascularity, a much better luteal phase support. It is going to definitely reduce the incidence of preeclampsia, IUGR, and it is going to give you a good pregnancy, which is going to go on till term. And simultaneously, the placentation is going to be good, right? So this is the theory. This is the theory which we all know. And we all think that, okay, we know everything about it. What I'm going to teach you in this 15 minutes exactly is how do you apply it in your practice. Okay. So on an average, if people, anyone has been following me or Dr. Sachin Dalal, most of the times people are aware that we are standardly doing 3-digit embryo transfers every month. Okay. And whenever we are handling such a huge workload, we have to ensure that things don't come to us on that Saturday, Sunday. You know, we don't want that weekend to get fired for doing a single embryo transfer. Apart from our wife killing us, the embryologist's wife will also kill him, and the staff who are married or have girlfriends will also die. Okay, just to give a 40-50% success rate to one patient, sacrificing so many men is really not very good in life, no. So with that thought, we came to a good idea of doing a modified natural cycle, which I'm going to project now. And Dipesh bhai, with your permission, I would just like to share screen. So just let me know, because once the screen is shared, I mean, once the whiteboard comes in, I will not be able to see anything. Okay. So I guess you guys can see the whiteboard now. Can you all see the whiteboard? Okay, yeah, okay. So everybody can see the whiteboard. Fine. So what we are going to talk about is something called as, you know, a modified cycle, a modified natural cycle stimulation. So I will just put it as modified natural cycle stimulation. Okay, so we've all understood this, that, you know, on day 2 or day 3, when the patient is coming to us for doing an ultrasound, you are going to have very small follicles which are going to be present, right? We all understand this very categorically. That is what is the antral follicle count. Okay, now I am preferring to do, this is just my thing, you may have your own criteria. So I am preferring to do the modified natural cycle preparations for patients in whom the AMH values are virtually normal. So AMH more than 1.5, 1.8. Antral follicle count should be present at least more than 6. Okay. Now I will give you a justification why I have chosen these criterias. The reason why I have chosen these criterias is because in these type of situations, when you are stimulating, the possibility of developing good oocytes is good. Okay, and you need a good oocyte to form in order for your modified natural cycle to be a success. You can't really have sort of an empty follicle. Okay, you can't really go in with an empty follicle and say that I am going to stimulate somebody with an empty follicle and still get the desired success rate. Okay, so what is your typical standard stimulation which people follow? Is very simple. Okay, we are going to use letrozole. Okay, in this situation we are going to use letrozole. This is our standard product. In fact, this is had not been married to would be married multiple protocols, very effective. So if the weight of the females is less than 70 kg, okay, then you normally give them just letrozole 001 for 5 days. Okay, if you are thinking that the patient is obese and all these things, you can have 101 for 5 days. This really does not make a big difference as far as any form of stimulation is concerned. Okay, what is going to happen to you? This is going to be your day 2 and day 3. Typically, when you have this type of a cycle, when you are stimulating with modified natural cycle, you are going to call this patient back to you on approximately day 10-11. Okay, so day 10-11, two things are important. You are supposed to look at the endometrium, and simultaneously you are supposed to look at the ovary. Very high chances that you will have one follicle. Okay, whichever protocol you have used, whichever you have used, very high chances that you will have one excellent follicle which has reached largest measurable diameter between 18 to 19 millimeter on this time. Okay, at this time, this is very highly possible. For a routine practical application, we are not monitoring PSV of every follicle. Okay, we are not really monitoring this PSV of every follicle when we are doing modified natural cycle. Trust me, we are not monitoring it. We are simultaneously looking at the endometrial thickness on the same day, and endometrial thickness is typically going to be between 7 to 9 millimeters. Sometime it may be less, sometime it may be more, but this is a typical correlation which you will see. And you are also going to get beautiful vascularity coming here. Okay, zone 3, zone 4 vascularity, what we typically want to assess on an ultrasound. Now, when you see this, okay, when this picture comes in front of you, okay, this is a standard case scenario which will come in front of you. When you have this picture, the best thing you can do, what you are doing in a complete natural cycle is you are waiting for this to rupture on its own. You are going to call the patient again. You call the patient again, the patient comes back to your hospital. You don't know when exactly it has ruptured. So it adds on to the monitoring. This is the advantage which you have when you are doing modifications, that when you are stimulating with letrozole, you have already got this. At this stage, you should go give 10,000 HCG. Okay, do not get into the system of giving just 5,000 HCG. Patient is less than 50 kg. I gave 5,000. 5,000 or 10,000 HCG really does not make a lot of difference. But it really helps when you have given 10,000 HCG, because you are sure that in more than 99% of the situations, it is going to rupture. Okay, we do not call the patient to verify rupture. We do not do this. Okay, we do not do this. So that extra visit is avoided. Okay, very, very simple. Very, very simple criteria which I'm going to present now to you is this, that when you have called this patient for doing all these things, and on this day, you have given HCG 10,000, and let's assume this day for you is Monday. Okay, I'm just giving an example. It could be today's what day? Today is Wednesday. So let's assume today is Wednesday. The lady came in today, and on Wednesday you saw this, you gave 10,000 HCG. So when should you do the embryo transfer? The rule is simple. It should be any time on next Wednesday. 7 days. Okay, anytime on next Wednesday. The logic is very simple. After you give HCG, it will be approximately 36 to 40 hours after which it will rupture. Okay, so this becomes your day 0. So embryo transfer in modified natural cycles to be done on day 7. Okay, for a blastocyst. So I am standardly doing only blastocyst, and as a result of which, it is a day 5 blastocyst which you are going to transfer on day 7. The commonest question which people are going to ask is, Jai, what if it is a day 6 transfer, day 6 embryo? What if it is a blastocyst frozen on day 6? Do we add a day to this? The answer is no. Day 5, day 6 blastocyst, as long as it is a blastocyst, you need to transfer on day 7, when day 0. So Wednesday to next Wednesday. Very, 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 very simple. Okay, very simple. The reason is modified natural cycle allows you to generate a very large window of implantation. Okay, the window of implantation is very, very big as compared to the routine HRT stimulation when you have done any form of natural cycle or a modified natural cycle stimulation. And that is something which you have to take home, because it really helps you enhance your success rates when you are doing it this manner and simplifying it. So the next question is going to come is that, Jai, all this is right. Okay. But, I had a specific situation. So there are only 2 specific situations which you are going to encounter, which I'm going to actually draw for you and make you understand. And it is very, very simple. Okay. So let's label it as special situation 1 and special situation 2. Okay. But let's assume that in both the situations right now, we are talking of Saturday. Okay. Let's say we are talking about Saturday. Okay. This is Saturday. Now, if somebody is like, has reached pioneering stage in life like Dr. Sachin Dalal, he can tell patients that I don't work on Saturday. Sorry, darling, come back to me on Monday. And patient will not say anything. Chupchap, they will go back home and come back. But let's assume you are as poor as me. So what is going to happen to you? Okay. You have sitting in your OPD Pavam on Saturday. You are about to go home at 5:30 and you have this beautiful patient who walks in. And now this person is 17 millimeter. Okay. And this is also 6.5. And this is your khatarnak patient. Okay. The patient who is micro monitoring IVF cycle more than you. Okay. So what will you do in this situation? Ab Saturday hai, you will say, "Arey, ek din ruk jata hu yaar. I will wait for 1 day." Okay, and मैं क्या करूंगा, I will wait for a day ताकि Sunday को rupture हो जाए. So by mistake this 17, let's say 1.4 millimeter it has grown, and 19 millimeter हो गया Sunday शाम तक, and it ruptured. Okay, so you are in trouble. Then you have to do your embryo transfer on the next Sunday ना, because it will rupture on Sunday. तो ये नहीं चाहिए अपने को. We don't want this to happen under any circumstances. Correct? So what do you do in this situation? See, the simplest thing you can do is you can just add half shot antagonist. Okay, if you are very economical. If you are not, you have a lot of money, no problem, just give one shot antagonist. Okay, just give one antagonist on this Saturday. Just give an antagonist. Patient को बोलो कुछ नहीं होएगा, come back to me on Monday. This single dose of antagonist will allow you to do two things. One, it will prevent your Sunday wala rupture, and second, in a special situation where endometrium has not caught up to the size of the follicle, it will allow the endometrium to catch up. Okay, try doing this in your practice. Okay, the endometrium will catch up to the follicle. Okay, and you will be easily able to prevent a Sunday transfer as well as have a lining between 8 to 9 millimeters by just a single shot of antagonist. Okay, how does this work? Mechanism of action I'm going to explain on WhatsApp. It is a very, very simple mechanism. Does addition of antagonist, okay, does addition of this antagonist cause any negative effect on endometrium? Okay, or does it cause any negative effect on synchronization or window of implantation? So the answer is no. A single shot of antagonist doesn't really cause this. Half shot of antagonist, the poor person does not cause anything to anybody. Understanding, it just doesn't cause anything to anybody. You are going to call this patient on Monday again, and what is going to happen is Saturday night का जो तुम्हारा antagonist गया है ना, she has come to you in the evening. So Saturday night antagonist given, Monday morning you call her, she will come, and Monday morning 8 o'clock, what is going to happen is this thing, the follicle no, has now actually become 19 millimeter, slightly bigger, 19.5 millimeter, and endometrium, because of your single antagonist, has got a nice window and is now 9 millimeter. Beautiful. Okay, beautiful 9 millimeter, and it is just, that early, very mild early changes of secretory things you are seeing. Okay, again, we don't do PSV. Even if we think it is about to rupture, we are going to give them 10,000 HCG, which is very, very simple. That remains the same, and embryo transfer will happen on next Monday. Okay, this is your take home point for your practical experience. And final thing, okay, where are you going to start luteal phase support? So this is the commonest question which everybody will ask, when to start LPS in this situation. Okay, so very simple, we will go back for the same lady. Monday ko she came, Monday ko you gave 10,000 HCG, and तुमने उसको बोल दिया embryo transfer on next Monday. ये तो तुमने उसको बोल दिया. Okay, let's assume this embryo transfer on next Monday is at 12 in the afternoon, 12 p.m. पर वो तो बहुत ही busy चल रहा था, so she came at 3 p.m. That is also okay. No problem. You can do it Monday anytime. Okay, it doesn't really matter. Okay. Now, when do you start luteal phase support? See, when you give your HCG 10,000, no, okay, actually may all these changes inside the follicle will actually start within 12 to 14 hours. Okay, within 12 to 14 hours, intrafollicular changes will really start. Okay, so normally what we advise people is that if you give HCG 10,000 on Monday, Wednesday morning, you are supposed to start luteal phase support. The luteal phase support which we provide to our patients is something called as progesterone gel. Okay, progesterone gel, 8%, one in the morning, one in the evening. Isko chhod ke we don't provide anything to these patients. Isko chhod ke we don't give anything. Somebody will say, nahi, but what if this 12 to 14 hours wala changes nahi hua? What if this thing did not rupture in that 1% situation? It did not rupture na? Kyun? Aisa hua to kya karega? Good. In that situation, you have already started on Wednesday and transferring on next Monday. So it has given 6 days of project. Very simple, na? Wednesday, Thursday, Friday, Saturday, Sunday. 5 days ho gaya. Monday is the 6th day of progesterone and you are doing transfer. Logic. Very simple logic. Somebody will tell you, अरे नहीं, but you know, instead of 12 to 14 hours, जो तू बोल रहा था कि जय, sometime it would rupture, let's say on Tuesday night को rupture होना चाहिए. It ruptured on Tuesday morning. Will it skip the window of implantation? Answer is no. It will not skip the window of implantation. उसका tension नहीं लेने का. Wednesday morning. Very simple. If this instead of Monday, very simple logic. If this instead of Monday becomes Tuesday, okay, instead of Monday, if this becomes Tuesday, तो क्या करेगा? Embryo transfer will go from Tuesday to next Tuesday. Wednesday की जगह पे it will become Thursday. Simple. Okay, very simple. Now there will be questions from people which is very understandable, that nahi yaar, you know, I don't really like to use letrozole. I am somebody who appreciates, and you know, I like to use only tamoxifen. Okay, listen, letrozole is something which is much more commonly available. Letrozole is something which you can by heart in your practice. Okay, don't really try to use tamoxifen for these type of indications. I will take a situation and a solution on when to use tamoxifen, okay, in your routine stimulations when patient is having low AMH probably. Okay, but apart from that, really don't end up using routine tamoxifen. Letrozole is something which is much better. It is something which is much standard. Okay, one good thing, when you do an embryo transfer with a modified natural cycle, believe me, your beta HCG values which you are going to get after 10 to 11 days, whenever you are doing your, you know, whenever you are doing your urine pregnancy test and beta HCG, oh my God, the values are going to be like 800, 1000. Okay, keep that in mind. It does not really indicate that it is twins and triplets. It just means that this is how it is for modified natural cycles. Probably it is due to a slightly better placentation is what I think. Okay, but I'm sure people who are doing modified natural cycles or natural cycles for that matter will agree to this statement as far as beta HCG values are concerned. Okay. The other thing people are going to ask is, in your luteal phase support, are you going to add estrogen? So the answer to that question is no, because the corpus luteum is very good when you have a modified natural cycle, and this corpus luteum is something which is very standardized, and this corpus luteum is going to secrete estrogen. Okay. Another question which commonly comes up when we are talking about modified you know, natural cycles to patients is, Jay, all this is okay, but you know, we had a patient in whom the patient came on day 2, day 3, but we had a follicle of 12 millimeter on day 3. Okay, so what is going to happen to this 12 millimeter follicle? Do you stimulate that or not? So it's very simple. You do serum estradiol on that day if you have the facility. See, we have an in-house laboratory. If the value of serum estradiol is less than 50, it indicates it is a non-functional follicle. Okay, in a non-functional follicle, you can simply give a single shot of antagonist and start your modified natural cycle from next day. Very simple. No rocket science. Just pre-treatment, 1 day antagonist. Estrogen is any which way is less than 50. जो कुछ भी बचा कुचा estrogen है, that single dose of antagonist will kill it. Okay, and you can start your stimulation from the next day. Okay. Second, people will ask that, do you measure estrogen, progesterone, and LH of these patients on, you know, when they are coming with this 18-19 millimeter follicles? See, the beauty is when you are using letrozole, the serum estradiol value is going to be 100, 90, you know, 80, 60, and you are going to get thoroughly confused. कि चालू किया तभी 40 था, अभी खत्म किया तभी 120 है. That means something is wrong. You know, nothing like that. Honestly, letrozole is something which is going to subdue it, and because letrozole subdues it, you need to be keeping that in mind. Okay, sometimes people will say, Jay, I am using it for an obese PCOS patient, a modified natural cycle. How do I go about it? Instead of 5 days of letrozole, give 7 days of letrozole in very severe and very obese patients. Okay, but I don't use it for them. I'm just telling you, if in case aisa hai kisi ko कि नहीं, I want to use it, okay, then you can probably use it in this manner. Okay. The other common question people ask is, what is the value of LH which you use as cutoff? कि भाई अगर मान के चलो LH surge हो चुका है, when the patient has come to you, LH surge has already happened. So that means all these things, Monday को अगर LH surge हो गया है तो Sunday को you will have to transfer. You won't have that window. See, remember, LH is secreted in a pulsatile manner. So it depends on what time of what peak the blood was drawn from the patient. And if in case you think कि अच्छा ऐसा कुछ हो गया है, then I will have to cancel and this modified natural cycle will go wrong. Which is why I'm saying don't get into that type of headache at all. Don't get into that type of headache. If that LH surge has occurred, no, and if it is a definitive LH surge, you are going to see early secretory changes in the endometrium. Baat khatam. You will see it. Believe me, you are going to see it. If you see early secretory changes, and in that situation, what will happen is the progesterone. If the definitive LH surge has occurred, the progesterone values will normally be more than 1.2. I use a cutoff of 1 to be super safe, but the values are going to be more than 1.2, and probably in that situation, you can either do a transfer one day before, okay? And if you are not confident of doing that, probably cancel that cycle and stimulate in the next cycle, okay? These are the commonest and the most standardest questions which people have always been asking as far as modified natural cycle is concerned. We have finished our 15 minutes. I will be answering rest of all the questions to everybody onto WhatsApp. Should people be wanting to see this again, this is available to all of you on YouTube. I thank all the 480, 490 people who joined. I mean, really, myself and Dr. Kiran sir and Shilpa madam and all this, Dipesh bhai, we had never expected when we started this series that 1,000 people would join in. And I think it is all the charisma of Dipesh bhai, Shilpa madam, and Sachin especially, that people are logging in such large numbers. So thank you so much, guys. I will stop the YouTube now. YouTube relay is about to get